The thing that has really obviously garnered not only the attention, but really the total focus of where we right now is this new coronavirus infection. This is a paper that Kat Paulus and Hillary Marston and I wrote just literally, a week or so ago, 4 or 5 days ago. It just is such a classic example of how viruses emerge. Some are trivial. I just remember the things I've told this council 30 times, 40 times. Is that if you look at emerging infectious disease, sometimes they're curiosities and sometimes they're transforming. And every once in a while you get one that's transforming. At least as far as China is concerned, this is transforming and maybe us ourselves. So it's very interesting. I'll just very quickly go through with this. And that's the reason why I lost my voice. I'm going through this too often. It's been identified a novel human coronavirus. It was an outbreak that was linked to a seafood market in China. But it's found out now that it wasn't that market itself that was the initial infection. The initial infection was in someone about almost a month earlier, in the beginning of December. The market infections were recognized on December the 31st. The market was an amplifier, not the source. Almost certainly, I hate to say certainly in biology, but almost certainly it was a jump from an animal to a human, and then it started to spread. The ability of a virus to adapt itself to spread. And as you know, the original reports from the Chinese was that this is animal to human and it's not spreading human to human. That's bad when you make statements before you actually can look and see what's going on. So December the 31st, the WHO was alerted to pneumonia in Wuhan. January 1st, the market was suspected. January 9th, the outbreak caused by a new coronavirus. January 10th, this was put on the public database. The 11th, the first death. The 13th, first case outside of China. 16th, Japan. 17th, screening passengers, first at 3 and then at 5 airports. The 20th, 14 Chinese healthcare workers, so much for no human-to-human transmissibility, as well as family clusters. Cases reported in the U.S., we now have 5 cases, and there will unquestionably be more, which is why I'm trying to tell the American people when I appear in the press that they shouldn't get like something brand new is happening when tomorrow you hear of the 6th or the 7th or the 8th case. They're all travel related from Wuhan. The Chinese, as I mentioned, put the draft genome on the public database, and immediately, as I'll mention in a second, we began working on a vaccine. Again, 5 airports. I learned things that I never knew before. That's, part of the job of maybe you should know things. There are 2 airports, New York Kennedy and San Francisco, that have actually had direct flights from Wuhan, a nonstop direct flight. The others have indirect flights. How many individuals from China do you think fly into the United States every day? 22,000 every day. 22,000. I didn't know that until Marty Citron, who's the head of our quarantine at CDC, told me that. So obviously screening is interesting, particularly in terms of whether or not it can be transmitted in an asymptomatic way. Okay, these were the first travel-related cases, starting the first one in Seattle, then Chicago, Orange County, LA County, and now Arizona. The Chinese are doing something that is completely unprecedented. It happened at the worst possible time of the year, namely during the Lunar New Year, which was January 25th, where, something like 100 and some odd million Chinese travel in crowded buses and crowded trains. The Chinese did something that's extraordinary. They've locked down the country. They've locked down a city of 11 million people. Wuhan has 11 million people. Could you imagine locking down New York City? They locked it down. They're locking down maybe 12 or 13 of the cities to try. And it's very interesting because that's a controversial public health endeavor. There are some that say it's never been done in this magnitude, so maybe it'll work. So you got to give them the benefit of the doubt. But the amount of fear and chaos of supplies coming in and out might actually be counterproductive. We don't know. I'm not passing judgment. I just don't know because it's never been done before to this scale. This is a picture, end of the world. This is the railroad station in Wuhan, which usually has hundreds of thousands of people running all over each other. They're stopped. 35 million people. Travel has been limited. I don't know. The WHO is going to meet again. I don't want to comment about declaring it a public health emergency of international concern. They've asked twice and they said, no, we'll see what happens this next time. Okay, so here's where we are. 5 confirmed cases, 100 patients are under investigation. Travel advisory, I've been doing this for a long time. I've never seen the State Department have a level 4. Namely, do not travel, period. CDC has a level 3 only because their level 3 is the highest they go. Their level 3 is if you go only with essential travel because that's a little bit different. These are the airports that are screened, and now the CDC is developed for testing and treating cases for the care of patients at home. So clinical guidance. Vaccines, we took the VRC, Barney Graham particularly, partnering with Moderna, a company that specializes in messenger RNA, to design a messenger RNA candidate. We will have it in phase 1 trial in 3 months. But be careful. I have to keep saying that over and over. Having something in a person in a phase 1 doesn't mean you have a vaccine that's ready for deployment, because it'll take another 3 months to get safety and immunogenicity data. And then even when you get that, you have to have phase 2, and then you got to scale up. So I have to keep saying over and over, yes, this is the fastest we've ever gone from sequence to phase 1 in our history. But that doesn't mean we're going to have a vaccine in 3 months. So what am I trying to tell you? That the way we're going to contain this outbreak is by classic public health measures: identification, isolation, and contact tracing. Okay. I will stop there. Are there any questions? Yes, Stan.
Could you comment on the possibility of antibiotic-based, antibody-based therapy?
Yes. Yes. We had developed, but never had to really use, antibodies, monoclonal antibodies against SARS and against MERS. If you look at the phylogenetic tree, this is between 75 and 86% homologous with SARS. So the idea arises that perhaps there's a degree of cross-reactivity, that you could use the monoclonal antibodies that you developed against SARS against this. The second level would be to get some specimens, which is the reason why we're pushing to get specimens. We haven't gotten them yet from the Chinese, but we now have 5 cases in the United States. So we're working very hard to not only get specimens of virus, but to also do leukapheresis and things like that. So monoclonal antibodies is going to be one of the things we're pushing for. So we're going to go into closed session.